everybody. There we go. Now we're live across all platforms, and good evening, America. I'm Dr. Randy Fink, and it is time for Fertility with Fink, the place that we go every Tuesday evening at this time, 5 o'clock. 5 o'clock Central Time, which means 6 o'clock on the East Coast, 4 in the mountains, and 3 on the West Coast. I am Dr. Randy Fink from New Life Fertility in Pensacola, Florida. I am in Panama City this evening at one of our satellite offices here. I also do some work at the Missouri Center for Reproductive Medicine, just outside of St. Louis, and at their office in Tulsa, Oklahoma, too. So good evening to everyone who is able to join us here tonight. And thanks so much for being here on this Veterans Day, with a special shout out to all veterans, especially in the place that I live here along the Gulf Coast, where there is such a very heavy presence of our military family. And of course, you may know that I came here from Colorado Springs, also a very heavy military presence. And military has been such an important part of our community in my life. I want to send a very special shout out to my dad, who retired from the United States Army as Captain Harold Fink, a pilot in Vietnam, who I understand for Veterans Day that he was able to make it down to the cemetery, the Veterans Cemetery, and was able to put on his flight suit that he last wore in 1962, which is very special. And I was begging to get a picture of that so that I could post it today, but I didn't get it. And I'm going to say that again because I think they're probably going to log on here at some point. And so I will send a special shout out to Dad. But to all our veterans out there, and to everyone who has veterans in their family, thank you so much to all who served. And Amber is saying that there as well. Thanks to all who served. That's Amber in Gulf Shores. Hi to Angela. Good to see you this evening. Hello to my dear friend Melissa. Noodles for Life. How are you? Jazzy Poo. Howdy. Hi Sheila. We've got Instagram. A couple of different Instagram feeds. This is Randy Fink MD right here. This is New Life Fertility's Instagram, and of course we have, as always, Facebook, LinkedIn, and YouTube right here in the middle. You know what we do here every Tuesday evening is have the chance to kind of talk about all those things that are important to us. That's things about making families, things about having babies, things about women's health. So please, I encourage you to throw your questions my way. And if you can't get to them, we don't get to them on the show here, I also have the ability to answer. We'll take your emails, and we will answer those at the top of the show next time. Some people don't feel comfortable reaching out in front of everybody here, and happy to do that personally. And that email address is askfertilitywithfink@firstfertility.com. And we do have a very special guest in Mobile, Alabama this evening, and that is my mother and father. And so since Mom and Dad, you joined the show a little bit late, you missed me talking about Captain Harold Fink and his contributions to our freedom and to our country. And so thank you very much for your service, not only to me and my family, but to our wider family and our country. Happy Veterans Day, and thanks for all you did. And the same goes out to everyone out there with a close connection or even a tangential connection to the military. This is a day we really celebrate all those people who have made sacrifices by leaving their families behind and going off to war, going off to train, going off to fight, going off to protect our flag and those things that we live for, and really take for granted, I think, the freedoms that we have in our country. Really, thank you so much to all of our veterans for everything that you've done for all of us so that we can all be here today. Hi to Wendy, and Angela said, I had a hysteroscopy this past Friday and they saw too much scar tissue everywhere that they couldn't get it all out. It's upsetting because I've done 8 transfers this past year with 20 embryos. Wow, I should have had a hysteroscopy prior to any transfers. Well, I do tell you that where I am, and it has always been my practice that we want to evaluate the uterine cavity uh, really before doing, probably at least once a year. But if something else happens, like a birth or miscarriage or a D&C or some other thing, then we want to evaluate that cavity precisely to make sure that there's no scar tissue and other kinds of things going on in there. For those who don't know, a hysteroscopy, hystero means uterus, scopy, hystero is uterus, scopy is to scope, to look inside. It's a little camera that goes through the cervix where we can take a look and see what we can see. We can see the openings of the fallopian tubes. We know what normal anatomy inside the uterus is really supposed to look like. So it gives us a chance to make sure that that is a comfortable and healthy environment, a great place for your embryo to implant. So, Angela, it concerns me there about that because part of that makes me wonder, well, where did all that scar tissue really come from? Did it come from a bunch of other procedures, or is it possible? Is it possible that maybe they were in the wrong place? And listen, that's no um, insult to your surgeon or to any gynecologist, because I am an extremely experienced hysteroscopist. That's probably one of the surgical an instrument-based surgical procedure that I do best. And I have gotten into the wrong place because, right, the cervix is a little tunnel that leads inside the uterus. And that tunnel, like any tunnel, has a way that it can go through there, right? But let's say that you get at a little bit of the wrong angle, and instead of going straight through the tunnel, maybe you end up going up into the muscle here. And if you do that, then it's possible that it looks like you're in a very scarred up and damaged uterine cavity. So if someone is telling you now that you have so much scar tissue on the inside of your uterus that your uterus is really not useful anymore, without having some major surgery to kind of try to fix that, my suggestion is that you do a secondary measure of that. For example, a saline sonogram. Do a saline sonogram or even an HSG if you want it, although HSG is not ideal for evaluating the uterine cavity. A saline sonogram is very good, especially with 3D ultrasound, where you can really see, well, gosh, what's the situation here? Were they actually in the right place? Is your uterine cavity truly damaged like that to the point where it's going to take some work to get it fixed back up? We've come a long way in terms of fixing up a damaged uterine cavity. We can oftentimes repair that scar tissue. That has a particular name. It's called Asherman syndrome. Asherman syndrome, and that's scar tissue inside the uterus where the top layer is basically kind of stuck to the bottom layer, and as a result the cavity itself is not smooth, and the endometrium, the lining, that glandular lining, is damaged to the point where an embryo may not be able to implant. Fixing Asherman syndrome is something that we can do. We've also done a big, there's a lot we have learned with using PRP, or platelet-rich plasma, inside the uterine cavity, which has your body's own healing tissue, your growth factors and things to be able to place inside that may allow that tissue to help heal up. Jay Bizzle, good evening, Jay Bizzle. My dear boy, Jay Bizzle. How do we repair it? And that is an excellent question. Usually we go in with a combination of a hysteroscope, which is that camera inside the uterus, and an ultrasound coming from above so we can really see where we are, and basically use a tiny pair of scissors and clean up that inside, separate the top from the bottom layers where they are stuck together, and then do some things to kind of try to keep them from sticking back together again. So that can be fixed. But Angela, going back to your original comment there, I would suggest maybe just a follow-up study to know that, in fact, that finding was real. Because if that's a surprise, then it bears looking into. It's very easy to do a different type of follow-up study just to make sure. Now, I wouldn't do another hysteroscopy to make sure. I'd say do another imaging modality that may show you a little bit more kind of what's going on the inside there. So thank you, Angela. And Jay Bizzle. Oh, and Angela says he also saw either a septum or a bicornuate uterus. He couldn't tell, so I'm having an MRI, and an MRI is an excellent way to be able to evaluate that. Let's see, got some other questions here, but before we move on to that, let's just say my fingers are crossed, as are yours. I hope that we are done with this shutdown business. I'm getting tired of it. I'm sure you're getting tired of it. All our friends who work for the government, they're certainly getting tired of it. Let's keep our fingers crossed there. I have really always felt, and I had occasion to share this today with folks. Just imagine what we could do, the things that we can solve, the progress that we could make if we were not also focused on who got the credit for it. That's true in our day-to-day lives. Unfortunately, we live for incentives. We all respond to incentives. But just think about it. If that wasn't so much a thing, we really could accomplish so much. And that is a very important lesson kind of to be had from our, to send on to our legislators, because they're the ones that are so worried about who's getting credit, because they don't want the other guy to get credit, because then that's going to affect them later on. And just stop that bickering. It's just not necessary. You may have heard me say once before, and again, I don't want to be political in this, but I will say this. If you can't sit in the bathtub with either all hot water or all cold water, you can't do fully one extreme or the other. It just doesn't work. You're either extremely uncomfortable because it's very cold on your bottom, or you're burning your ass off, quite literally. You need some combination of both the hot water and the cold water. That's how you make warm water, and that's tolerable. So electing to have some political position that is extreme over here or extreme over here, our society needs coming together. It needs blending. It doesn't need polarization. And again, just my 2 cents worth there. All right, moving right along. Thank you for indulging me. Hey, Tamiji, nice to see you this evening. And Wendy, hi, Noodles for Life says, what cycle day to perform uterine PRP to help a thin lining? I'm about to start suppression with Orilissa for 60 days. So if you're going to be, so you want to be able to do that PRP during the cycle of your treatment. So Noodles, if you're starting suppression for endometriosis with Orilissa, you're going to be doing that for 60 days. And when you come off the Orilissa, hopefully you'll be going right into a treatment cycle. And that's really when we see the best results after suppressing endometriosis. So now, I don't know if you've had a history of having a thin lining before, but basically what I would say is that day 4, 5, 6, 7 in your new cycle, depending kind of on when you start using your estradiol, that is when I would recommend that you do your PRP. So kind of what you want to be able to do is do it initially early on in that cycle before that lining really has a chance to start growing, because it's not that you're treating lining, you're treating the basement level there where that lining is actually growing from. So I would treat it early, and then it may be that you need to treat it again sometime close to or around mid-cycle if it's not actually really doing its thing there as well as you want for it to. Now, I will tell you there are some other things that we can do that are really very helpful to help aligning. So Viagra is one answer to that. Viagra increases the blood flow. They've studied it to see, well, does it really help very much for women in terms of sexual response the way it does in men? And unfortunately, it really didn't, which is, to Pfizer's sadness, because, they had this incredible blockbuster drug with Viagra treating half the population. If there was only a pill that you could take for the other half of the population, then, that would have been a big financial boon for them. But not so effective in that regard. However, it does increase blood flow to the endometrium, as does a baby aspirin. There are a couple of different forms of estrogen. There's vaginal estrogen, there's oral estrogen, there's transdermal estrogen, and there's even injectable estrogen, which actually works really well. It's called delestrogen. It's dirt cheap. You do an injection every other day, and that's one of the things, kind of one of the secrets in the armamentarium to get a lining to respond and grow if it's just really not doing all that well. So just a thought, but I would say early on in the treatment cycle, don't do it while you're under suppression for endometriosis while you're on the Orilissa, because I don't think that'll make a difference. You want some of that lining to have started to grow back so that you have, really something that you can treat there. Fertility Action, thank you for being here this evening. And let's see what else we got. Florida Girl, howdy. Oh, my little friend Timmy. Hello, Timmy. I hope you're watching. Ange, it looks like Ange May, thank you for being here. Florida Girl says, I'm currently pregnant. Oh, dang, girl, congratulations. That is wonderful. I am happy to hear that. It's funny because I feel like I know everybody here. I've been seeing your, I see your names around, and I feel like, I am your doctor. I feel like we're old friends and maybe even family to some degree. So now I find out you're pregnant. It makes me really happy and very, very proud for you. So I'm so happy to hear it. Currently pregnant from my November the 1st frozen embryo transfer, and my clinic said to go off of baby aspirin. I'm also on Lovenox. I have MTHFR, so I'm nervous to go off the baby aspirin. What's your recommendation? So I would say no, I don't stop baby aspirin now. I take it at least through the first trimester. So Lovenox and baby aspirin, you would think, gosh, aren't those two things the same? They're both, designed to be some form of blood thinner. And while, yes, that's true, they have a different mechanism. They do some different things at the level of the endometrium. They're kind of treating a different pathway that is designed to try to help you maintain the pregnancy. So, now, if that came from your fertility specialist that said to stop, there may be some reason that they felt that you should stop doing it. But in general, I tell people continue on the baby aspirin. The other thing is that baby aspirin may also decrease some risk for hypertensive disorders later in pregnancy. So I certainly do take it through first trimester there. Now, as for the MTHFR mutation, and let's talk about that a little bit, because it's something that used to be very common, very commonly tested. MTHFR, and I just like to say it, it stands for methylene tetrahydrofolate reductase. And I just like to say it because it makes me sound, as though I'm incredibly intelligent. It's just because I memorized the words. Methylene tetrahydrofolate reductase. And in the methylene tetrahydrofolate reductase department, this evening we've learned Yeah, no, MTHFR. It is a mutation that it's believed that really is probably up to a half the population may have, and it has to do with the way that we metabolize our folic acid. Folic acid, as you know, is critical for the development of the what we call the neural tube, which becomes the brain and the spinal cord, and so that's why the recommendation is that we should be on folic acid for at least 3 months prior to conceiving. We used to think that a defect in the gene that encodes for this particular enzyme, MTHFR, was associated with recurrent pregnancy loss. That is, when you had that defect, it meant that there was a problem in the way you handled your folic acid that may increase your likelihood or the probability of miscarriage. And what we know now is that that is not the case. MTHFR is not associated with anything bad. I do not consider it a dangerous thing. Now, there are some conditions later on in life that can increase your level of homocysteine, which is a clotting related biochemical in the body that is related to folic acid. But in general, as it pertains to pregnancy loss, MTHFR is not a thing. So I don't feel like you need to worry about that. Okay. Kind of important. So you got enough other things to worry about there, Florida girl. Take that one off the table. But in my book, I stay on the baby aspirin at least through the end of the first trimester, and the same with the Lovenox. Congratulations again. Gosh, that is just so wonderful. Hey, Natalie, nice to see Natalie Foster here this evening. Is that the Kaylee Gordon? Hello, Kaylee Gordon. Kaylee Gordon is a nurse practitioner extraordinaire and an IVF coordinator at our practice in Pensacola. And I thought Kaylee was like in Italy or something this week. So Kaylee, if you are tuning in from Italy, then you are truly a good Samaritan. And ciao, skol. No, that's not it. What do we say? Arrivederci. No. Thank you for being here. Amber says, I'm 2 weeks away from my transfer. I'm currently taking estrogen and soon progesterone. Why do we thicken the uterine lining in IVF, meaning during my 2 non-IVF pregnancies, I never took these? Well, it's a good question. And that's because in your pregnancies before, you had natural hormones that were doing that for you. So what happens in the menstrual cycle? How does the doggone menstrual cycle actually work? Well, first of all, you got to make yourself a nice, big, thick, juicy, warm lining for an embryo to be able to implant. And that's really the purpose of having that uterine lining. And when it figures out that you're not pregnant, let's say at the end of a natural cycle, your progesterone level drops, and that's what causes you to slough that lining off, because the brain and the body is saying, oh man, we're not pregnant. Okay, fine. Shut off the hormones, clean everything out, and we're going to try again next month. And that's that signal for you to get a nice normal period. So estrogen causes the lining to get nice and thick and warm and juicy. That's my medical terminology for it. Nice and thick and warm and juicy. When you start your progesterone, and this is in a medicated cycle, progesterone causes that lining to start to compact. It's starting to get like kind of pushed down so that it's getting even more ready to accept the embryo. It changes the appearance of that lining when we look by ultrasound. And in a natural cycle, when your ovary releases an egg, it's that egg that's growing in the ovary that's making your estrogen. And when the ovary releases that egg, that little egg house becomes your progesterone factory. And that's called a corpus luteum in the ovary. And that's where your progesterone comes from. Now, in a medicated cycle for an embryo transfer, all that stuff is not happening, right? We're suppressing that with the medication because we are trying to control every aspect of that embryo transfer. We're trying to control all the variables so that there is nothing left to chance that we are in control of it all. That's a medicated cycle, and that's how it's done. Because we're suppressing the body's ability to make those hormones, we're going to give them to you because we don't want your body to decide to do it differently. So that's why in a medicated cycle for a frozen embryo transfer, we do the estrogen and the progesterone. Now, you may know some people who in pregnancy use some progesterone after they've ovulated, and sometimes that's a thing. There is another way to do an embryo transfer, and that's in what's called a natural cycle. And in a natural cycle, you don't have to use the medications. We let your body take front seat to making those hormones. So either you ovulate on your own or we get you to ovulate. As that egg is growing, you're making your own estrogen, which is thickening your own lining, and it does that same doggone thing every single month. Then you release your egg, and then you start to make your own progesterone, and then then you have an embryo transfer, and that's how that works. And that's what's called a natural cycle, and it's just a different way to do it. But that's a great question, Amber, and I appreciate you asking it. Let's see, a special hello also to, oh gosh, Max is even here, or at least Max was here up in Fort Collins. Thank you for being here this evening, sir. Zamina says, can the endometriosis come back if it has been treated with antibiotics? So I think we might be talking about something different there. So endometriosis is the process where the lining of your uterus, instead of sloughing off and coming out the door, instead works its way up north and implants in sites around your pelvis. It can then start to interfere with your hormones and the way your brain is talking to the organs down south, right? That's endometriosis. I think you may be talking about endometritis. Endometritis is an infection or an inflammation, in most cases, of the endometrium, which is that lining of the uterus. So we can test the lining of your uterus to see if there is some little smoldering fire. Because if there's an acute infection inside the uterine lining, you're pretty sick. It often turns, pus is kind of coming out. You have a fever, you have pain. People can get, septic from that. People can get very sick from it. People often have to be, hospitalized for that. But sometimes there's not actually an acute infection, but rather some chronic little smolder. Think about that it's like a little smoldering embers there. And that's called chronic endometritis. And we can test for that in an endometrial biopsy. And when we find it, we typically treat you with an antibiotic. And an antibiotic most commonly used is 2 weeks of a medicine called doxycycline. Twice a day for 14 days. And usually that puts out the fire. Now, it doesn't always. The recommendation now is that we do a test of cure to make sure that it's gone. Now, interestingly enough, I never did that test of cure because there are some people who are just kind of chronically colonized with some sort of bacteria on the inside there. And it may be that chronic inflammation is never really turned off, that we're never really able to get rid of it. So I never was a big believer in doing a test of cure. But what we know now is that there is very clear data that says that if you are treated for chronic endometritis based on the results from an endometrial biopsy, that we do a test to make sure that chronic endometritis has indeed resolved, that pregnancy rates are higher when we do that. And so I do recommend a test of cure. So to answer your question, can endometritis come back if it's been treated? The answer is yes, it can come back again. It's sort of like, well, if you got pneumonia, And I hope you don't get pneumonia. But if you got pneumonia, could you get pneumonia again sometime later in your life if you took antibiotics to make it go away? And the answer is, well, yeah, of course you can. If you caught a cold, could you get a cold again? Well, you're not immune from it. It doesn't give you immunity. But not the bigger issue is not, did you get it again? But the question is, did the 2 weeks of antibiotics actually make it go away? That's kind of my bigger concern there, Zamina. So, hey, folks, guess what time it is? It's about 1/2 past the hour, which means it is time for 5:30 Fuzzies, Fink's 5:30 Fuzzies. They're the 5:30 Fuzzies with Fink. And what is this? And why does he keep talking about that? Oh, a special hello to Shadia and my friend Red Bear. I haven't seen you around for a while. If you're still with us there, good evening. Nice to see you. 5:30 Fuzzies with Fink is the time that we can all get together, that we can say the names out loud, and that we can all band together as one community, standing together as one, sending out the good wishes, sending out positive vibes into the universe, all at one time. This business of fertility, this business of trying to stay healthy, this business of really honestly trying to keep a positive outlook on life when it seems like so many things around us are trying to tell us that things are negative out there. It's hard to do. If you're going through fertility treatment, if you're going through fertility woes, things aren't working the way you wish they were. If you're going through health concerns, family concerns, relationship concerns, I imagine that there is a huge community of people, especially the people who tend to come to this broadcast, who would stand with you, put an arm around you, hold your hand, be a shoulder to cry on, be a source of light and answers to your questions, so that I want everyone to know that they are not alone in this adventure. So, who are we talking to tonight? We've got Sheila, we've got Elizabeth Shalom, we've got Red Bear, Shadia, we've got Zamina, we've got Angela, Lovely Onyx, Melissa, Anya, AZ Signatures, Yvonne, hi Lexi, to Ocean, to Beach Bum, to Grace and the Florida Girl, and Katie Flores, to Erica, to Lama Muher, I believe, to my friend Amber, to Esty Sunshine, to Kowser, to Emily and Harold, to Sarah, to Expectingish, I like it, to JB and Max, to Noodles, and to Jazzy Poo. Let's all again stand together as one community and say, you got this, friends. You are not alone. Positive vibes to everyone. Let's do it together right now. And that, my friends, is the 5:30 Fuzzies with Fink. Thank you for participating in that. And gosh, if you can get anybody, any friend of yours to join, even if it's just for 5 minutes next Tuesday, maybe at 5:25 or 5:29 at 30 minutes past the hour. I try to do this thing every Tuesday as part of this show, and it's becoming a popular thing, and I think it's good because you know what? This is how we can make a change. Be kind to other people, and I think everyone here would agree with me on that. So thank you very much. Okay, moving right along. Oh, let's see. Going back to Angela's question here, I had a hysteroscopy 2 years ago and had one a year and a half ago, and it was all clear. Could scar tissue appear out of nowhere? You know, it can, depending on what kind of stuff has gone on inside your uterus there. But again, I think what you're talking about is a surprise, right? This is not something that you expected. And that's why I'd say, I just want to take another look. And again, I think a saline sono is a comfortable and straightforward, easy way to kind of reevaluate the uterine cavity. See if there's any scar tissue by another imaging modality. You may not see that by MRI, by the way. So just to be aware. Okay, what else we got going on now? Melissa says, I'm really struggling. Well, I'm not glad you're struggling, but I'm glad you're here. You're in the right place. Two miscarriages. And my last two embryo transfers have failed. I'm not getting much guidance on what next. Our embryos are untested, low grade. Any suggestions? So the answer to that is yes. Okay, so let's kind of talk about some general stuff here. Melissa, I don't know a lot about your individual situation other than what you've talked about, but here's my general approach to things and things that might just turn out to be helpful. So, when we talk about miscarriages, the most common reason miscarriages occur is because of chromosomal issues. We know that the embryos that you have remaining here are untested, and you've had the two other embryo transfers that did not give you pregnancies. So it makes me kind of wonder, well, about egg quality. But really, at this point, we can't think too much about egg quality. We've got embryos, and we want to get those embryos in, and we want to give them their very best chances of working. Because they're made, right? And we don't know. You could go back and test those embryos. I wouldn't attach too much significance to the embryo grade, because I will tell you that if the embryologist feels strongly enough that that embryo is good enough to freeze, then 1000% that embryo is good enough to get you a baby. And embryo grading is kind of just a beauty contest, and I don't want you to attach too much significance to that. But you could go back and test the embryos and see which are are any of them chromosomally normal. That can put some stress on the embryos, and it's a kind of a big cost. So I wouldn't necessarily recommend that you do that. So again, let's take genetics out of the equation and say, well, again, it's out of our hands at this point because those embryos are made. Is there anything that we can do that may just improve chances? And the answer is possibly. And so here's what I would do. There are some supplements, 6 of them to be precise, that you should be on, and that everyone who is doing an embryo transfer should be on. Prenatal vitamin, vitamin D, vitamin E, CoQ10, L-arginine, and omega-3. If you have a history of endometriosis, then you want to add vitamin C to that. So those 6 things are the evidence-based protocol for embryo transfer. Do it. Is there any reason you shouldn't do it? No, do it. And people say, well, what about acai berry and what about ashwagandha? They're all fine. They're all okay. They're antioxidants and that sort of thing. But the evidence-based protocol, the things that have been shown to work: prenatal vitamin, vitamin D, vitamin E, CoQ10, L-arginine, and omega-3. Do it. The next thing I would say is, well, all right, have you evaluated the uterine cavity? And like we talked about a little bit earlier about hysteroscopy, I would want to know for sure that your uterine cavity is clear, that there's no scar tissue, that there's nothing inside that's going to prohibit your beautiful embryo from implanting. The other thing I would want to know in this situation is, have you been evaluated for endometriosis? Now, endometriosis, as we talked about, is something that can confuse the way the hormones talk to the organs. Specifically, as it pertains to embryo transfer, it's less associated with a miscarriage like you had in your first 2 there, but more associated with implantation failure. Classically, endometriosis had to be diagnosed through surgery, through a laparoscopy. Nowadays, we can diagnose endometriosis non-invasively, and that's through a test that's called Receptiva. And if you're not familiar with it, you can look it up, receptivadx.com. And it looks for a marker. The marker is called BCL6, and it is highly associated with endometriosis. So if you've got endometriosis, it may be trying to prevent your embryo from implanting. I would certainly think that that's worth looking into. There's a couple of other medicines that in your situation now I would think about using. I would want to know, do you have any sort of autoimmune type problem? And how do we judge immune problems? Well, sometimes we just say, well, maybe there's something there. But we can do two blood tests. One's for something called anti-thyroid antibodies. The other is called an ANA, an anti-nuclear antibody. And it's not that these two are so specific that, oh gosh, there's something wrong. In fact, they're pretty, other than the thing for the thyroid, the ANA is very non-specific, but it tells us that your immune system is revved up and doing something to try to fight against you. And if that's the case, there are specific medications that we can use to sort of turn that down. Plaquenil is one such medication for the ANA. Sometimes we want to optimize the thyroid. There's low-dose naltrexone. There's prednisone that we may use to kind of bring your immune system into check. Additionally, there is a medicine called tacrolimus or Prograf, and I would recommend that you consider, it's certainly something that I would consider using because it is associated with helping people who have an immune problem where their body is rejecting the pregnancies. And it works really, really well in that regard. So I think, Melissa, there's probably an awful lot of I's to dot and T's to cross. I know that you are struggling in dealing with this because it sounds like having had to deal with 2 miscarriages and then 2 FETs that did not get you a pregnancy makes this really one crappy roller coaster ride for you. Right? Am I right? I'm pretty sure I am. It is no fun to ride that roller coaster. What's the best thing that you can do? Well, to be honest with you, we don't know where this roller coaster is going to go. We can't predict the next turn. We can't predict whether it's going to go up or down or twist this way and move our head and hurt our neck and make you want to vomit. And it's a roller coaster that really feels like it's out of control. What can you do is to make sure that every I is dotted and that every T is crossed and that nothing has been missed or left to chance. That's kind of the way I think about it. And that's how we try to get in control of a situation that feels very much out of control. My gestalt for you, Melissa, is that there are happy times ahead, and we are all here with you. Fingers crossed, positive vibes right to you. Anya, I think I said hello and hi to Yvonne and Lexi. I hope you're feeling well with your early pregnancy. A special hi to Grace. Thank you for being here. Hi, Katie Flores. Pardon me. Beach Bum asks, what happens if the lining doesn't shed well and you start out thick at the baseline? How is the transfer affected? That is an excellent question. So, we usually look to see at the beginning of a menstrual cycle that the lining is at its thinnest because you've sloughed it off in the cycle before. You got your period, so it kind of should have all come out. If that lining is really thick at the beginning of the cycle, it starts really to make me think, well, is there something else going on in there that's making that lining look thick from the perspective of the ultrasound? Is there a polyp that didn't go away that's still hanging out there? Is there some scar tissue? Is there a little ball of muscle like a fibroid? Is there something else in the cavity? So if that lining is thick, I'd say, persistently thick, it warrants taking another look. We like it to be completely thin because we like to know that when that lining sloughs off, that you've really rebooted the whole system, that it's all come out and that it's ready to sort of start all over again. So yeah, it can affect a transfer, but the most important feature there is not so much what's it going to do, but what is it trying to tell you? And in my opinion, it's trying to say maybe there's something still going on inside the uterus here and we ought to know what it is. So in that scenario, I'd say, well, gosh, depends on how thick it is. we want it to be 3-4 millimeters at the beginning of the cycle, and if it's 5 or 6, well, that's not a deal breaker. If it's 9 at the start of the cycle, wow, that's like 2 to 3 times thicker than it should be. Something is not right, and I would say not a good cycle to do a transfer. I would want to sort that out before I put an embryo inside. Um, Let's see. Are the same hormones responsible for the 10 pounds of weight gain I had since my retrieval? Uh, well, um, certainly couldn't have anything to do with all the public's birthday cake that you eat every single day, right? No, I'm just kidding about that. So, hormones get blamed for a lot of things, but in this situation, yeah, you at the going through egg retrieval, we're doing a lot of stuff with hormones there. In some cases, you may have been on a steroid, and the steroid can cause you to retain water. A lot of it, may end up being something that's temporary, like sort of some fluid retention. Now, sometimes it may actually be that you put on weight, and that probably has to do with your own steroids, with your own cortisol, which is your body's stress hormone, which has you trying to retain, basically trying to store energy as fat because it wants to give you some quick access to something if you need it for fight or flight. Um, so yeah, it certainly can be, and hormones change a lot of more subtle things, like they may change the way you think or feel about food. The food noise may increase, and so and then certainly we know that once we do get pregnant, we don't lose weight typically. Now, sometimes people do lose weight because they get nauseated or vomiting or just don't feel like eating. But weight gets to be one of those things that is, kind of always a real challenge. And yes, sort of hormones are to blame, but it's not the sort of thing that you say, clearly it's because your estrogen level is at a 150 instead of 100. And so therefore, if we just withdraw some estrogen, then you'll lose all that weight. Unfortunately, it's so multifactorial, and hormones do so much in so many different pathways that it's very hard to kind of pin the tail on exactly where that issue is. But you are right; the struggle is real, and the truth is, of course, eating Publix birthday cake for lunch every day is probably not the best idea. I was kidding about that. I know that you don't really do that. Hi, SD Sunshine, and let's see. La Mujer says, "Can you explain how a medicated cycle works? I know the protocol, but I don't fully understand how we get pregnant without ovulating and having a corpus luteum." Hey, yeah, absolutely. Like we sort of talked about before, the natural cycle, you make some estrogen, you make some progesterone, and you make estrogen from the follicle that you're building up. Then you ovulate, you release that egg, and when you release that egg, you start making progesterone. Well, so in a medicated cycle, we're just giving you that estrogen to build up your lining and giving you that progesterone so that it's the same kind of levels that your body would naturally make. It's just kind of coming from the outside. And in a medicated cycle, it just means that we can keep those levels very constant, and they're very predictable in terms of the way that your body is going to absorb them. So that's how it's done in a medicated cycle. We're just mimicking the same thing that your body does when you ovulate and have a corpus luteum. And La Mujer, that is an excellent question. You get a gold star, ding, for that. Thank you. Thank you for asking. Angela says, can endometritis cause scar tissue? Not typically, no, because it's a chronic inflammation. Well, I mean, I suppose it probably could, but that's really not one of the things that I'd never say never, but that's not sort of what we kind of think of as being a cause. Usually it is some sort of more acute inflammation. So let's say that you got an infection on the inside. It was a really bad infection. And that kind of inflammation can cause the top and the bottom layers to kind of stick to one another and may damage the endometrium. But the chronic inflammation is really identified by the presence of an immune cell called a plasma cell. And there's a special lab test that we do for that. It's looking for a marker that's called CD138 in the tissue that comes out. And it's usually pretty straightforward to treat. But the thinking with chronic endometritis is that it may be that it causes inflammation such that the embryo itself doesn't want to implant in that lining because there's a smoldering fire there, but not so much in terms of scar tissue. But I'd never say never. I like that name, expecting-ish. That's cool. Sarah is here. Good evening. Hi to Jay and Sharmila. Thank you for being here. Dr. Fink, last year, November 8th, you did my transfer, and baby Anya is here now. Boy, that November the 8th. Wow. So 1 year ago, we did a transfer. Isn't that unbelievable? Gosh, Sharmila, and you have a beautiful baby. I'm so happy for you. Really just fantastic. Hey to Cat B. Hi, Lala. Nice to see you. And Zinni says, oh, hello, Dr. Gonk. You don't know my name by now. Oh, there, you corrected it, Dr. Fink. But you may call me Dr. Gonk if you wish. That would be a first, but okay. Hey there, down in Miami, in sunny South Miami, and happy Veterans Day. Right back at you. Blaxican Beauty, good evening, my friend. Beach Bump says, always clear of anything else. Oh, because we were talking about the lining there. The thickness only happens after transfer meds. So I guess you mean that you're getting, you're trying a transfer. If the transfer is not successful, then your baseline the next month, the lining is thickened. I'd really want to take a look at that. So, and really the other question is, well, how thick are we talking about? Because again, if it's a little extra millimeter or two, then I don't think that that's as big a deal. But if it's double the thickness or 3 times the thickness, something else is going on there in most people. And it may also just be really honestly that ultrasound is not a great tool to measure your lining. There are some people who every single month it looks like that lining is at a 12 at the beginning of the cycle every time we measure it with ultrasound. And then we go and actually look. Let's say maybe we do a hysteroscopy and put a camera in it, actually look with our eyes and see what's in there. And we find that, oh gosh, after all that, there's nothing there really at all. And then that's just, well, okay, so this means that that's just kind of the way it looks on ultrasound, but ultrasound is giving us a false positive. So it kind of makes me wonder there about that as well. Anna Suasen, thank you for being here this evening. Hi, Rose Kelly girl. Kowser, my friend, says, hey, I had my embryo transfer today. Excellent. My hormone levels were, my estrogen was about 89. My progesterone was 33. I was advised to take estrase 3 pills orally and 1 pill vaginally daily. Can you please confirm if this dosing and timing is important and appropriate for supporting implantation? Well, I think it kind of depends. Are you doing a medicated cycle or are you doing a natural cycle? Because if you did a natural cycle and you used letrozole, then your number is going to be what's called a modified natural, then your estrogen number there is going to be artificially low. Truly, the estrogen number doesn't so much matter as long as the lining is thick enough. However, if this was call it a medicated cycle and they measure that number, sure, I'd say a little bit more estrogen probably is useful. But I'm guessing that this was a natural cycle because it doesn't look like you were on any estrogen before. So given that scenario, and my guess is you probably used letrozole for ovulation induction, which is going to make your number low, which means extra estrase doesn't make a damn bit of difference. And I wouldn't have checked it, and I wouldn't do it because that's a fake number. So again, cows are not really sure exactly what they did there, but hopefully that's helpful. Black Skin Beauty says, is it normal not to see much of anything on a 5-week, 1-day ultrasound. Absolutely normal. I transferred 2 embryos. Let's see, and I only saw a little bit of a sac, embryo transfer on 10/17, and I would say, yeah, that is kind of to be expected. At 5 weeks, you'll see a little bit of a sac on the inside, but you're probably not going to see a lot else. Now, a week from now, you may see an awful lot different. So yes, indeed, early on in the pregnancy doesn't really look like a whole lot. So a sac inside the lining, especially if your beta HCG number is above about a 1500, should confirm that that pregnancy is inside the uterus. But as far as seeing, some of the other structures associated with that pregnancy, so that'd be things like a yolk sac or what we call the fetal pole, and certainly seeing the heartbeat, you will not see that. You will not see the yolk sac and that sort of thing till a little later on, closer to 6 weeks, and the heartbeat usually not until between 6 and 7 weeks. So congratulations, you got something going on there, friend. That is incredibly good news. I'm happy to hear it. Hey, Meg Johnson, and hey to Jackie. And gosh, it's been great to see everybody this evening. We're going to run out of time here at the top of the hour. Again, a very special shout out to all the veterans, to Captain Harold Fink, the wonderful Cowser said, I gotta repeat this. My husband is telling me that your mustache style is very good looking and suits you very well. Well, thank you. Thank you very much. It means a lot to me. I appreciate that. Hey, this fertility business is not the story of your life. It is not your novel. It is only a chapter. And what are we here to do? We are here to rewrite that thing, and we're here to do it together. Every step forward with love, my friends. Every step forward with kindness. There is not enough kindness in the world. Be kind to strangers. Smile at somebody for no reason. And be here next week for the 5:30 Fuzzies with Fink, so that we can send out all those good vibes. And know that every step forward is one of hope, because tomorrow is a new day full of all new adventures. So until next week, I'm Dr. Randy Fink. Thanks so much for being here, and good night. Bye.